Today, we're undertaking a really deep detail and frankly essential dive into the literal machinery of pain relief.
hmm
We are talking about the foundation of modern analgesia, opioid analgesics, and their antagonists. This is a class of drugs defined by, profound power, but equally profound risk.
It really is.
We've taken chapter 34 of an incredibly dense pharmacology text, and we're focusing exclusively on synthesizing the molecular keys and the clinical consequences for you, the learner.
That's absolutely right. Our mission today is to move past just the general knowledge and really drill down into the mechanisms.
Right.
We need to synthesize this technical material to understand not just that these drugs work, but precisely how they interact with the body's own natural systems.
Because understanding that molecular choreography is really the only way to grasp why they're so good at relieving suffering, but at the same time, why they present such serious issues with dependence.
Exactly. And with adverse effects, it's all connected at the receptor level.
Okay, so let's unpack this with some initial definitions. The whole topic really starts with pain itself. The clinical term we see in the sources is analgesia.
Mm.
I mean, we all know what pain feels like. But what exactly is this unpleasant sensation on a physiological level? Why does the body even create it?
Right. So analgesia is defined as an unpleasant bodily sensation that's perceived as suffering. It's usually caused by noxious stimuli, external threats or internal damage.
It's a warning system.
Fundamentally, it's protective. It is the body's essential warning signal, forcing us to withdraw from a hot stove or protect an injured limb. It drives survival.
But the source material makes this really critical point. When pain becomes excessive, it actually stops being a useful warning signal and just becomes debilitating in itself.
Precisely, yeah. Once it crosses that threshold, it causes a whole cascade of secondary symptoms. You get intense apprehension, sweating, nausea, palpitations.
And that rapid, shallow breathing, what's the term? Tachypnoea.
Tachypnoea, that's the one. At that point, the pain itself is causing the distress. It's taxing the patient's entire system rather than serving any useful protective function anymore.
So that's where we introduce the analgesics. This entire class of drugs has one very specific job.
An analgesic is designed to selectively relieve pain. It does this by acting either on the central nervous system, the CNS, or on peripheral pain mechanisms.
And the crucial distinction here, the thing that makes them so valuable, is that they do this without significantly altering consciousness.
That's the key. They allow the patient relief and rest without inducing heavy sedation or, full general anesthesia.
So it's about relieving the symptom, the suffering, when the underlying cause can't be immediately fixed. That seems foundational to their medical use.
Indeed. We use them when that noxious stimulus can't be removed right away, like after major surgery or during a chronic illness. They treat the suffering, the symptom of pain, even if the underlying pathology is still there.
Now, the pharmacology text breaks analgesics down into three broad categories. We should probably mention them quickly, but it's pretty clear where we're focusing today.
Right, so we are locking our focus entirely onto the first category, the opioid narcotic or morphine-like drugs.
Okay.
The other two categories are the non-opioid, non-narcotic anti-inflammatory drugs, like your NSAIDs, which are covered elsewhere. And then you have the adjuvant analgesics.
And those adjuvants are kind of like support players, right? They help manage the chronic or like the neuropathic parts of pain.
Yes, exactly. They include things like anticonvulsants, gabapentin, pregabalin, and certain antidepressants like amitriptyline or duloxetine.
So they modulate nerve function, but they're not the heavy hitters.
No, they're not the primary powerful relief agents that opioids are. So our deep dive today is purely into the opioid class, and we're starting right at the source.
Right. And this is where the history meets the high-stakes chemistry. It all starts with the poppy.
Yeah.
So for you, the listener, what defines opium as the source material for this whole drug class?
Opium is a dark brown resinous material. An exudate, really.
Hmm?
It's obtained by incising the unripe capsule of the poppy plant, Papaver somniferum.
So it's basically a sap.
It is. And this resin is, in effect, a natural pharmacological cocktail. It contains two very distinct categories of alkaloids.
And these two categories determine the plant's biological activity. We're talking about analgesia versus, well, everything else. Let's detail them and identify the compounds we actually care about for pain relief.
Okay, so the first, and by far the most important group, are the phenanthrene derivatives.
These are the heavy hitters.
These are the powerful analgesic agents. They include morphine, which makes up about 10% of opium and is the prototype for the entire class. And we also find codeine, which is present at about 0.5%.
Now, here's where the chemistry provides a really fascinating contradiction. The source mentions a third phenanthrene derivative, the bane, but it explicitly labels it as non-analgesic.
Hmm.
Why is this structurally similar molecule completely lacking in pain relief capability?
That's a great question. And it really highlights how just slight structural differences can completely change receptor affinity. Thebaine, though it's chemically related, makes up about 0.2% of opium,
A tiny amount.
a tiny amount, and it just doesn't engage the critical pain-relieving receptors in the same way. It is non-analgesic, but it is used commercially as a precursor to synthesize other semisynthetic opioids.
So if the bane is non-analgesic, what about that second major class of alkaloids in opium?
Those are the benzoquinoline derivatives. These are also non-analgesic. This group includes papaverine, which is present at about 1%, and noscapine, which makes up about 6%.
And what do they do if not relieve pain?
They often have smooth, muscle relaxant properties, but they do not provide that characteristic, CNS-mediated pain relief that we associate with the opioid class.
So when we talk about potent system-changing analgesia that comes from the poppy, we are really just talking about morphine.
At its core, yes.
So let's pivot to the prototype itself. Its pharmacological actions, especially the ones centered on the central nervous system, are what define this entire class of powerful painkillers.
Absolutely. Morphine's effects, and they are both depressant and stimulant, which is interesting, and the CNS are driven by its powerful interaction with the mu opioid receptor.
The mu receptor.
Morphine has the highest affinity for mu-A, which makes it the standard, the benchmark, by which all other powerful opioids are measured.
And its most critical action, obviously, is analgesia. We're talking about a drug that can mitigate severe pain, but the mechanism described in the source is it's dual. It's not just about stopping the physical sensation.
The strength is paramount, yes, but that dual nature of the relief is perhaps its most beneficial clinical feature. Morphine not only decreases the physical sensation of pain, but, and this is critical, it suppresses the emotional and affective components of suffering.
So the anxiety, the distress, the fear.
Exactly. The fear and the apprehension we talked about earlier.
So for a patient with, say, a traumatic injury or a terminal illness, the pain is still there, but it's no longer perceived as this crippling catastrophe.
Precisely. It makes the pain subjectively bearable.
Yeah.
And this dual action happens across multiple sites in the nervous system. At the spinal level, morphine acts in the dorsal horn, specifically in the substantia gelatinosa.
And that's where pain impulses are gated, right? Tell us more about that gating mechanism.
So morphine acts on inhibitory interneurons in the substantia gelatinosa. By activating these inhibitory pathways, it blocks or significantly reduces the release of excitatory neurotransmitters that normally transmit pain signals up the spine.
Neurotransmitters like glutamate?
Glutamate and substance P, yes.
Yeah.
It effectively closes the gate on those ascending pain signals.
And at the same time, it's also working at higher centers in the brain.
Yes, supraspinally. Action in areas like the periaqueductal gray matter, the limbic system, the cortex, that alters the interpretation of pain. This is where the emotional dampening happens.
Right.
It's the combination of shutting off the traffic at the spinal gate and changing the mind's emotional reaction to the traffic that's already moving that gives morphine its immense power.
Moving beyond just pain relief, morphine is famous for inducing sedation. Now, this isn't anesthesia, but a very specific state of mind.
Right. Sedation occurs in parallel with pain relief. It's a state of drowsiness, mental dullness, and sort of indifference to the surroundings.
But the patient is still awake.
The patient is relaxed, but it's distinct from true hypnosis or general anesthesia because they remain easily arousable. The goal is to calm the distress and allow rest without knocking the patient out completely.
And here's where the pharmacology turns into the societal problem: subjective effects and euphoria. This is the reinforcing pathway that makes morphine the prototype for addiction.
Yes. The subjective experience is complex. It involves detachment, reduced anxiety, a relaxed feeling in the limbs, and a cloudy mental state, an inability to concentrate.
For a patient in agony, that must feel like a miracle.
For a patient in pain, this release is profoundly pleasant. It's relief.
But for an individual seeking the drug non-medically, that same feeling is amplified into something much more intense.
Absolutely. For addicts, it results in a powerful kick or a rush, an intensely pleasurable, floating, almost ecstatic sensation. And this profound reinforcing effect is the key to its addiction potential.
And we can trace that directly to the molecular level.
We can. It's the release of dopamine, DA, in the nucleus accumbens.
Okay, let's slow down on that molecular hijacking. How does morphine, a pain reliever, manage to trigger the brain's primary reward chemical?
So it works by inhibiting the inhibitor. The nucleus accumbens is the key pleasure center in the brain. Normally, you have these GABAergic neurons that act as brakes, preventing excessive dopamine release.
Okay, so GABA says slow down.
Right. And opioid receptors are located on these GABA neurons. So when morphine binds to the melioreceptors on these inhibitory GABA neurons, it shuts them down.
So if you silence the brakes, the GABA, the accelerator, dopamine is just free to flood the reward pathway.
Exactly. By inhibiting the inhibitor, morphine dramatically increases the release of dopamine into the nucleus accumbens. And this massive, unnatural DA surge creates that intense euphoria and the powerful drive for repetition, which is the definition of psychological dependence. It is the core mechanism.
The core mechanism that defines the addiction profile of all strong mido agonists.
That's it.
We've established the chemical foundation of relief and reward. Now we have to look at the flip side, the systemic actions that define the danger profile. These are the effects that dictate why this class of drug must be monitored so closely.
And we have to begin with the most dangerous adverse effect: respiratory depression. This is the ultimate cause of death in an overdose, and it's a constant clinical risk.
Explain the mechanism. Why does morphine suppress breathing?
It's entirely dose-dependent, and it results from a depression of the medullary respiratory center. This depression makes the center far less sensitive to the primary physiological trigger for breathing, which is carbon dioxide.
So as CO2 builds up in your blood, which should make you breathe faster.
Normally, yes. The brain detects that acidity and increases your respiratory rate. But morphine just blunts that sensitivity.
So even as the CO2 builds up to toxic levels, the brain doesn't register the alarm.
Correct. The patient's respiratory drive slows down, often becoming shallow and inadequate, leading to dangerously low oxygen saturation and high CO2 levels, hypercapnia.
And the source material warns about specific risk groups who are acutely vulnerable to this.
Oh, absolutely. Patients with pre-existing pulmonary diseases like COPD or emphysema are at marked risk because their respiratory mechanics are already compromised. For them, a relatively small dose of morphine can tip them into respiratory failure.
And what about long-term use?
Chronic opioid use, especially at night, can lead to serious central sleep apnea and subsequent hypoxic brain damage over time. This effect makes monitoring a patient's breathing non-negotiable.
Okay, so moving from respiration to cough suppression. It's interesting that morphine is a stronger cough suppressant than it is a respiratory depressant.
Yeah, that differential action is what makes certain derivatives so clinically useful. The suppression occurs because morphine acts centrally to inhibit the cough center in the medulla.
So it takes less of the drug to stop a cough than to stop breathing.
Exactly, which is why codeine and its derivatives are still widely used for symptomatic cough relief.
Okay, next, let's address the paradoxical effects. Nausea and vomiting. Why would a drug that calms the central nervous system also trigger such distress?
This effect is usually observed shortly after administration, and it's due to two simultaneous factors. First, direct stimulation of the medullary chemoreceptor trigger zone, or CTZ.
The CTZ.
The CTZ is basically the blood-borne toxin sensor for the vomiting center. Morphine activates it. Second, it stimulates the vestibular apparatus, which means the nausea is often made worse by movement.
So just sitting up or moving your head can make you feel sick.
Precisely. It's a temporary, highly unpleasant side effect that often requires co-administering an antiemetic drug. We should note that while initial doses stimulate the CTZ, very high doses of morphine may eventually suppress the vomiting center itself. But the initial response is typically emetic.
Got it. Let's look at the cardiovascular system, the CVS. We saw earlier that morphine is often used to treat a heart attack, a myocardial infarction. That implies a beneficial circulatory effect. How does it achieve this?
So morphine is a vasodilator. It relaxes blood vessels through three main pathways. It depresses the vasomotor center, which regulates vessel tone. It has a direct tone-reducing effect on the vessels themselves, and significantly, it promotes the release of histamine.
The histamine release is key. We usually think of that in terms of itching or an allergy.
In this context, the histamine release contributes heavily to systemic vasodilation. The overall effect is a decrease in systemic vascular resistance.
And what does that do to the heart?
Well, morphine has minimal direct effect on the heart muscle itself, but it can decrease the heart rate bradycardia due to reflex vagal stimulation.
And the clinical consequence for the patient's circulation?
Blood pressure falls. This is generally therapeutic in conditions like pulmonary edema. Because the vasodilation decreases the pressure the heart has to pump against it, it reduces the preload.
But it comes with a risk.
A big risk. Postural hypotension is a serious concern. When a patient stands up quickly, they can experience a rapid, dangerous drop in blood pressure.
Now, we have to talk about the gastrointestinal tract actions. This is arguably the most common and persistent adverse effect of the entire class: constipation.
This is the signature adverse effect.
Yeah.
It's chronic, it's debilitating, and it's inescapable.
Right.
And clinically, this is critical because chronic users never develop tolerance to the constipating effect.
Never.
Never. It remains a lifelong problem for those on chronic opioid therapy.
Why is it so uniquely effective at stopping GI transit? I mean, it's not just slowing things down, it's practically a full stop.
It acts through a powerful two-pronged mechanism on the enteric nervous system and the GI mucosa. First, it drastically reduces propulsive movements, the peristaltic waves that push material through the intestines. Everything just slows to a crawl.
Okay, and the second prong?
It clamps down on the exits. Morphine significantly increases the tone of the major sphincters, the pyloric sphincter, the ileocecal valve, and the anal sphincter. So you've reduced movement combined with high resistance at the barriers.
A traffic jam with roadblocks.
A perfect analogy. And the central action also reduces general propulsive reflexes. The result is dry, hard stool that is incredibly difficult to pass.
Wow, that is a critical detail. Okay, moving beyond the GI tract, the source mentions spasm of other smooth muscles, particularly the sphincter of Oddi.
Yes, and this is a vital clinical detail because it contraindicates morphine use in certain acute scenarios. The sphincter of Oddi controls the flow of bile and pancreatic secretions into the small intestine. Morphine causes it to spasm,
Which can cause immense pain.
excruciating biliary colic. And if the patient already has an undiagnosed acute abdomen, this spasm can be disastrous.
How so?
Well, if there's an obstruction or some pathology already there, the severe spasm can build pressure to the point of potentially rupturing the gallbladder.
So you can't give morphine until you know what's wrong.
Precisely. It's a prime example where the pharmacology directly impacts surgical readiness.
What about the bladder, another smooth muscle organ?
Same principle. The tone of both the detrusor muscle and the bladder sphincter is increased. This gives the patient the sensation of urinary urgency, but makes micturition, urinating extremely difficult.
Leading to urinary retention.
Often, yes. Catheterization may even be necessary in postoperative patients on high doses.
We also need to flag the warning for asthmatics. Why is morphine so dangerous for them?
It comes back to that histamine release we discussed in the cardiovascular context. That same histamine also affects the bronchi. Morphine causes bronchoconstriction, which is a significant danger in patients with asthma or other reactive airway diseases. It can acutely trigger a severe asthma attack.
And finally, for this section, let's explore the chronic hormonal impact, the neuroendocrine actions. These effects often lead to long-term quality of life issues for heavy users.
Right, so morphine dampens the activity of the hypothalamus, which is the control center for the pituitary gland. This disruption reduces the release of essential reproductive and stress hormones.
Things like FSH and LH.
Follicle-stimulating hormone, luteinizing hormone, and also adrenocorticotropic hormone, or ACTH.
And what are the physical manifestations of that reduced hormonal output?
For heavy opioid abusers, this hormonal shift often leads to significant clinical issues like loss of libido, impotence, and menstrual irregularities in women.
So it really disrupts the whole system.
It does. And while full-blown clinical hypoadrenalism is rare, the loss of reproductive function is a major consequence. Interestingly, morphine also slightly decreases antidiuretic hormone, ADH, which actually increases urine volume.
But that's probably masked by the urinary retention.
It often is, yes. The mechanical problem overrides the hormonal signal.
Okay, so now we're going to transition into pharmacokinetics, the study of how the body actually interacts with the drug. Understanding this is what determines the proper clinical route and dosage.
And we had to start with bioavailability, which is notoriously poor for oral morphine. The problem is what we call high first-pass metabolism.
Explain that first-pass issue in depth for the listener. What does that really mean?
Okay, so when morphine is swallowed, it passes through your digestive tract and then goes directly to the liver via the portal circulation before it ever reaches the rest of your body.
And the liver is a processing plant.
A highly effective metabolizing machine. It rapidly breaks down a huge percentage of the dose. As a result, only about 1/4 of the orally administered dose actually reaches the bloodstream intact.
Which explains why injected or parentally administered morphine is so much more effective.
Exponentially more, yes.
So once it is in the plasma, where does it go?
About 30% is bound to plasma proteins. It's highly distributed throughout the body. And clinically, It's vital to remember that it crosses the placenta.
Right.
For a mother receiving morphine during labor, the drug can cross over and concentrate in the fetal brain, potentially affecting the fetus more severely than the mother.
How does it manage to cross the blood-brain barrier to exert its effect in the first place?
Well, it is lipid-soluble enough to cross the barrier, but actually only a small fraction gets into the brain. Crucially, that fraction is metabolized very rapidly once it's inside the CNS, even faster than it is in the plasma.
Let's discuss metabolism in detail, because this is where the body creates both the drug's best asset and one of its greatest liabilities, the active metabolites.
This is a complex but absolutely vital detail. Morphine is primarily metabolized in the liver through conjugation with glucuronide. This process produces two major metabolites.
And the first one, morphine 6-glucuronide, is almost like an unintended chemical upgrade.
That's a perfect way to put it. Morphine 6-glucuronide, or M6G, is an active metabolite. And what's astonishing is that M6G is actually more potent than the parent drug, morphine, at the opioid receptor.
Wait, so the body processes the drug and creates a more powerful painkiller?
It does. And it contributes significantly to the overall analgesic effect, especially after repeated dosing.
Wow. So what about the other side of the coin, the second metabolite?
That would be morphine 3-glucuronide, or M3G. This metabolite is neuroexcitatory.
So it does the opposite of pain relief.
It doesn't contribute to analgesia at all. Instead, it can cause agitation, hyperalgesia, which is increased pain sensitivity, and other CNS stimulatory effects.
I see the clinical implications here immediately. If a patient has impaired kidney function, they can't clear these metabolites efficiently. They'd build up.
It's exactly. For patients with renal failure, the accumulation of M3G can lead to neuroexcitatory toxicity. We're talking tremors, even seizures. And at the same time, the buildup of the highly potent M6G can lead to unexpected, exaggerated opioid effects, including severe respiratory depression.
So it makes drug selection incredibly complicated in those patients.
Very.
Given all this complexity, how quickly is morphine cleared from the body?
Excretion is rapid, primarily through the kidneys. The plasma half-life is short, usually 2 to 4 hours. However, the duration of analgesia is slightly longer, lasting about 4 to 6 hours, partly thanks to the contribution of that potent M6G metabolite.
Let's just quickly summarize the general adverse effects, the things a patient is most likely to complain about clinically.
The common list includes sedation, mental clouding, lethargy, a dysphoric or depressed mood, that persistent constipation we discussed, generalized sweating, blurring of vision, and urinary retention, and of course the ever-present risk of respiratory depression.
What about true allergic reactions versus something like generalized itching?
True, immune-mediated allergic reactions, like urticaria, swelling, anaphylaxis, are surprisingly rare for opioids. The common symptom of itching, or pruritus, is usually a result of that nonspecific histamine release we talked about earlier.
So it's a pharmacological effect, not a true allergy.
Correct, though it can be intensely irritating for the patient.
And the major clinical crisis related to distribution, apnoea of the newborn.
If morphine is administered to the mother during labor, it concentrates in the fetal brain and can cause neonatal respiratory depression. The treatment there is immediate intervention.
Using naloxone.
Specifically, the administration of the opioid antagonist, naloxone, to the newborn to reverse those effects.
Right. Let's turn to the concepts of long-term risk. Tolerance and dependence. What defines tolerance?
Tolerance is the phenomenon where the effects of a drug diminish with repeated use. This forces you to take higher and higher doses to achieve the same initial effect.
And this happens on 2 levels.
Yes, it occurs simultaneously on the pharmacokinetic level. The body just gets better at metabolizing the drug, and on the pharmacodynamic cellular level, where the reproductive systems change their sensitivity.
And tolerance develops rapidly to the good stuff, the analgesia, the euphoria, the sedation, and also the most dangerous part, the respiratory depression.
Yes, so a heavy user needs exponentially more drug just to get high, or even just to feel normal.
But here is one of the most striking details in the pharmacology. Tolerance is not exhibited to 2 major actions.
That's right. You never develop tolerance to meiosis, the pinpoint pupil, or to constipation.
So wait, you're telling me an addict could need 100 times the initial dose to get high, but they will always have pinpoint pupils and, well, they'll always be constipated.
That's exactly right. These effects persist indefinitely, regardless of the dose or the duration of use.
That persistence is a diagnostic tool, isn't it? Pinpoint pupils are a telltale sign of active opioid use, even in long-term abusers who are tolerant to everything else.
Precisely. And the dependence itself, the physical and psychological need, develops very rapidly with chronic use. While proper medical use rarely leads to that addictive behavior we associate with abuse, physical dependence is inevitable when the body adjusts to the constant presence of a strong agonist.
And when that constant presence is suddenly removed, we get the withdrawal syndrome or abstinence syndrome. Detail the manifestations of that physiological backlash for us.
The symptoms are profoundly distressing. It involves intense drug-seeking behavior paired with severe physical manifestations.
Like what?
These include marked sweating, continuous yawning, lacrimation tearing up rhinorrhea, which is a runny nose, severe abdominal colic, diarrhea, hypertension, and rapid weight loss. The body is effectively over-rebounding from being suppressed for so long.
It sounds horrifying, but the source notes two symptoms that are not characteristic.
Yes, this is an important point for differential diagnosis. Unlike withdrawal from alcohol or barbiturates, convulsions and delirium are not typically seen during pure opioid withdrawal.
Okay, finally, the crisis scenario. Acute morphine poisoning. Overdose. What is the classic clinical triad?
The presentation is unmistakable. You have stupor progressing to coma and flaccidity, shallow, slow, inadequate breathing, which is severe respiratory depression, and the characteristic pinpoint pupils or meiosis.
Coma, respiratory depression, meiosis.
That's the textbook definition. As the condition worsens, you see cyanosis, a significant fall in blood pressure, and shock. Pulmonary edema is often the terminal event.
What's the lethal threshold for a non-tolerant individual?
It's estimated to be around 250 milligrams in an adult who has no tolerance, but this is where tolerance shows its power. For an addict, the source notes that even 50 milligrams injected intramuscularly can cause serious toxicity. It just shows how close chronic high-dose users operate to their maximum tolerated threshold.
And the treatment is immediate and life-saving. We have to emphasize the protocol for the specific antagonist, naloxone.
Treatment is aggressive and multi-pronged. You need supportive care, especially positive pressure respiration and maintaining blood pressure, and, if possible, gastric lavage. But the definitive life-saving step is the immediate intravenous administration of naloxone, starting with a dose of 0.4 to about 0.8 milligrams.
Now, here's the critical insight that often dictates the difference between recovery and relapse after initial treatment, the half-life problem.
This is perhaps the most important clinical detail about naloxone. Its duration of action is extremely short, only 1 to 2 hours.
Compared to morphine, which lasts 4 to 6 hours.
Right. This means that the naloxone can wear off while the opioid agonist is still circulating and still active.
So the patient can wake up, seem fine, be medically cleared, and then relapse back into respiratory depression and coma an hour later.
Exactly. Naloxone must be repeated every 2 to 3 minutes until respiration is stabilized, and then maintained via repeated dosing or continuous infusion for several hours to prevent the patient from sinking back into a life-threatening state. Understanding that timing mismatch is essential for saving lives.
We've seen the systemic chaos and the clinical crises caused by morphine, but none of this is possible without the molecular keys. How did scientists find the locks for the poppy, the specific opioid receptors?
The search for the mechanism, spurred by the potency of morphine, led to the discovery of 3 main receptor types through sophisticated chemical modification and radioligand studies. We have mu, kappa, kappa, and delta.
And the distinct profile of each receptor explains the diversity across the whole opioid drug class.
It does.
Let's start with the big one, the mu receptor, morphine's primary target. What is the pharmacological checklist for a drug that is a strong agonist?
The new receptor dictates the strongest effects, both the desirable ones and the undesirable ones. It is responsible for powerful supraspinal and spinal analgesia, intense dose-related respiratory depression, profound sedation, euphoria, meiosis, reduced GI motility, and crucially, the highest potential for morphine-type dependence.
So the mu receptor is the target if you want maximum pain relief, but it comes with the maximum risk.
It is a high-stakes receptor.
So if mu null means euphoria and addiction, what happens when a drug targets the kappa receptor instead?
The kappa receptor offers a very different profile. It mediates spinal analgesia, though often with a lower ceiling of efficacy than euphoria. It also causes sedation and meiosis, again, generally less intense than the mu null effects.
But it has a unique twist.
It has a unique and vital contribution: dysphoria and psychotomimetic effects. This means it can cause feelings of unease, sadness, or even hallucinations and altered perceptions.
That is a fundamental chemical differentiator. One receptor provides a rush, the other provides distress. That seems to be a major target for designing safer painkillers.
Absolutely. The natural ligand for kappa is dinorphin A. Drug designers are always looking for ways to maximize analgesia from other receptors while minimizing moodal activation to reduce abuse potential. But that accompanying dysphoria from kappa activation often limits its clinical appeal.
And finally, the delta receptor. What are its main roles?
The delta receptor contributes significantly to analgesia. It covers both the spinal component and the affective or emotional component of pain relief at the supraspinal level. It's also involved in respiratory depression, affective behavior, and GI motility. And it's implicated in the reinforcing or addictive actions, though perhaps less profoundly than the maltol receptor.
So we have the locks. Now let's talk about the key mechanism, how opening these locks actually shuts down the pain signal. The source tells us all three receptors are GPCRs. Explain that receptor transducer mechanism.
Right, all three types, methyl, the kappa, and delta, are G-protein coupled receptors. This means when an opioid binds, they initiate an intracellular signaling cascade. And crucially, they are located mostly on projunctional neurons, the neuron before the synaptic gap.
So we can think of these receptors as molecular traffic controllers sitting on the exit ramp, regulating what signal is allowed to pass.
That's an excellent analogy. When an opioid like morphine binds to this projunctional receptor, the GPCR activation triggers three main inhibitory events that shut down the traffic.
Okay, event 1. Blocking the signal transmission itself.
They inhibit the release of excitatory neurotransmitters, like the glutamate and substance P we discussed. The message simply doesn't get sent across the junction.
Event 2. Hyperpolarization.
Activation causes the opening of potassium channels. When potassium rushes out, the neuron becomes hyperpolarized, meaning its electrical potential becomes more negative. This makes the neuron far less likely to fire an action potential. It's essentially switched off.
And event 3. Calcium restriction.
They reduce the availability of intracellular calcium. Calcium is essential for releasing neurotransmitters. By restricting it, you stop the neuron's ability to communicate. The net effect of these three actions is an incredibly efficient, generalized inhibition of pain signaling.
This entire sophisticated molecular system confirms the suspicion that morphine was just hijacking a natural system. So let's dedicate some time to our body's own built-in pain relievers, the endogenous opioid peptides.
The discovery of these peptides in the 1970s was revolutionary. They're naturally occurring compounds that act as our internal agonists, regulating pain, stress, and mood. We have three major families.
Tell us about the endorphins.
So beta-endorphin is the most important peptide in this class. It's 31 amino acids long. It is primarily a diagonist, though it also has some delta activity. Its potency is staggering. When injected into the brain, it is estimated to be 20 to 40 times more potent than morphine.
20 to 40 times, wow.
It plays expansive roles in pain control, mood, pleasure, and pituitary hormone release.
And the enkephalins.
Enkephalins, specifically MET-ENK and LU-NK, are smaller pentapeptides. They're highly important in modulating pain sensitivity, and they show affinity for both MES and delta sites, though they have a higher relative affinity for delta.
And the dynorphins, the ones linked to that dysphoria receptor, kappa.
Correct. Dynorphins are peptides ranging from 8 to 17 amino acids, and they are the potent primary endogenous agonists for the kappa receptors.
Finally, we have the newcomer, nociceptin orphanin FQ, or NOPQ, which seems to be the wild card of the endogenous system.
NOPQ is a novel peptide that acts via its own receptor, the NOPQ receptor. It is implicated in many complex behaviors: stress response, reward, learning, memory, and pain control. What makes it unique is its complex role. It can act in both opioid-like ways and, critically, as an anti-opioid or antagonist.
So it's more of a modulator.
A powerful modulator rather than a simple on-off switch.
The big takeaway here is that the immense power and risk of morphine are only possible because it perfectly intersects with a highly complex natural system that evolution designed to manage suffering.
That's right. With the receptor map clear, we can now look at how other major opioids diverge from morphine, which often dictates their unique clinical utility.
Let's start with codeine, the other naturally occurring analgesic alkaloid.
Codeine is actually methylmorphine. It's chemically modified. As a result, it is far less potent, about 1/10 the strength of morphine. However, it exhibits a fascinating property. It's more efficacious via the oral route.
Why is its oral bioavailability better than morphine's?
Codeine has to be metabolized in the body into active morphine to exert most of its analgesic effect. Because it's a prodrug, it avoids some of that rapid first-pass metabolism that destroys pure morphine.
So it's mainly used for less severe pain.
For mild to moderate pain, yes, but its most selective use is in suppressing cough. It acts on the cough center, and it's about 1/3 as potent as morphine in that specific role.
Next up, the synthetic agent pethidine. also known as meperidone. What were the clinical drivers behind creating this alternative to morphine?
Pethidine was historically seen as an attractive alternative because of key differences. It's faster acting, but has a significantly shorter duration, usually 2 to 4 hours. And critically, it has less of that spastic action on smooth muscles.
So less constipation and less biliary colic, addressing two of morphine's major side effects?
Exactly. It was seen as safer in cases of abdominal pain. However, pethidine has a major toxicity drawback we have to highlight, the accumulation of its metabolite, norpethidine.
And norpethidine is a neuroexcitatory agent leading to a serious risk.
A very serious risk. Norpethidine accumulation, particularly in patients with impaired renal function or those receiving multiple doses, can cause tremors, hyperreflexia, and dangerous generalized convulsions.
Which has limited its use now.
Severely. Also, pethidine has antimuscarinic action, which causes the opposite effect of morphine on the heart. It often increases heart rate or tachycardia.
Okay, moving to the powerful, ultra-fast agents used primarily in anesthesia, fentanyl and remifentanil.
Fentanyl is enormously potent, 80 to 100 times more potent than morphine. Its utility comes from its high lipid solubility. It just zips across the blood-brain barrier rapidly, peaking in minutes.
But its duration is short.
Very short, around 30 to 40 minutes after an IV injection. This rapid onset and offset is why it's invaluable for anesthesia and why it can be formulated into transdermal pain patches.
And remifentanil is the sprinter of the group.
Remifentanil is chemically designed for ultra-rapid inactivation. It has an extremely short duration of action, peaking in 5 to 10 minutes and lasting only 3 to 10 minutes overall.
So it's for minute-by-minute control?
It's the gold standard in specific anesthetic procedures where the level of opioid action must be titrated constantly.
Methadone is another synthetic agent, but its defining feature is its long half-life, which makes it crucial for dependence management.
Right. Methadone is chemically similar to morphine, with good agonist activity, but it has excellent oral bioavailability. Its key feature is its duration of action. It can last 24 to 48 hours with chronic dosing.
And that stability and long duration make it the cornerstone of substitution therapy.
Methadone is essential for treating opioid dependence. Its prolonged action prevents the severe, rapid withdrawal associated with short-acting drugs like heroin, allowing for a gradual, managed detoxification.
Now let's discuss the atypical opioids tramadol and tapentadol because they don't rely on the BAW receptor alone.
These are hybrid drugs. Tramadol is a weak NEET agonist, but its main mechanism involves inhibiting the reuptake of norepinephrine and serotonin.
So it's fighting pain on two fronts, the opioid receptor and the monoamine system.
Exactly. Because of this dual action, its analgesic effect is only partially reversed by naloxone, which demonstrates that a significant portion of its pain relief is non-opioid mediated.
What's the major warning for tramadol use?
Tramadol significantly lowers the seizure threshold. This makes it contraindicated in patients with a history of epilepsy. Tapentadol is a newer analog, also binding to the newer receptor and inhibiting norepinephrine reuptake, with its primary activity focused on those central NE pathways.
We have to address the complex action opioids, the agonist-antagonist drugs designed to walk that fine line between potent pain relief and minimized abuse.
These compounds are pharmacological paradoxes. They are often partial agonists at the GORDID receptor or full agonists at the kappa receptor, while simultaneously acting as antagonists at mu.
And because they are only partial agonists, they have a lower ceiling for respiratory depression and euphoria.
Making them less addicting in theory, yes.
The primary example here is buprenorphine. It has a complex relationship with the mu receptor.
Buprenorphine is a partial agonist and a kappa antagonist. It has a very long duration, 6 to 8 hours. Because it has such a high affinity, but only partial efficacy at the buprenorphine receptor, it can actually displace full agonists like morphine.
Which means if you give buprenorphine to a patient who is already dependent on a full agonist, you trigger a disaster.
Yes. If administered to an opioid-dependent individual, buprenorphine will bind tightly to the buprenorphine receptors, kick off the full agonist, and because it only provides partial activation, it will immediately precipitate a severe acute withdrawal syndrome.
So its timing is critical.
Critical. But this unique property also means it can be used effectively in substitution therapy for dependence, often in combination with naloxone to prevent diversion.
Finally, let's circle back to the pure opioid antagonists, the ultimate reversers of opioid action.
These are competitive antagonists at all three receptor types. They produce absolutely no subjective or autonomic effects in individuals who have not received opioids. Their function is strictly to block the binding site.
Naloxone is our prototype for acute poisoning reversal.
Naloxone has the highest affinity for opioid A receptors. It is the drug of choice for acute overdose reversal. But we must stress again its short half-life of 1 to 2 hours, which necessitates repeated dosing.
And the longer-acting alternative, which is active orally.
Yeah, that would be naltrexone. It's structurally similar to naloxone, but is effective orally and has a significantly longer duration of action, sometimes lasting 1 to 2 days.
Which makes it better for long-term treatment.
Ideal for opioid blockade therapy. It's given to recovering addicts to prevent the effects of a relapse. It's also used in treating alcoholism, which is interesting.
Yeah, that speaks to the connection between reward pathways and the various receptors.
It does. And we should briefly mention nalmefene, a naltrexone derivative, which is noted for having an even longer half-life and better oral bioavailability, potentially offering more sustained blockade.
After charting this massive territory of receptor science and adverse profiles, it's vital to ground this knowledge in the real world, the clinical applications where opioids are truly indispensable. What are the primary defining indications?
Analgesia, without a doubt. They're indicated for moderate to severe acute pain, so things like major surgery, severe trauma, or burns. They're also non-negotiable for managing the chronic pain of terminal illnesses like cancer.
The sources mention patient-controlled analgesia, or PCA. What makes this technique superior for post-operative pain control?
PCA allows the patient to administer small, controlled doses of the opioid intravenously when they feel pain, usually within predefined safety limits. It's superior because it overcomes the lag time associated with waiting for a nurse and ensures the analgesic is given before the pain becomes overwhelming.
So it provides more consistent relief.
Better pain control with often a lower total drug dose, yes.
We highlighted earlier that morphine is uniquely beneficial in a heart attack. Why is it used beyond just pain relief?
It's vital intervention because it reduces the load on the heart. By causing vasodilation and reducing systemic vascular resistance, it decreases the heart's workload.
Preload and afterload.
Both. This shift in blood volume from the struggling pulmonary circuit to the systemic circuit helps relieve the acute pulmonary congestion and edema that often follows a heart attack. It is both an analgesic and a cardiovascular aid.
The sedative and emotional dampening effects are also harnessed directly in acute trauma settings, aren't they?
Yes, the relief of anxiety and apprehension is a therapeutic goal in itself. In severe trauma or major internal bleeding, the calming effect of morphine stabilizes the patient psychologically, which helps clinicians stabilize them physiologically.
This leads us directly to another application, acute left ventricular failure and pulmonary edema.
Morphine is a cornerstone of treatment here, again leveraging its ability to reduce preload and systemic vascular resistance, improving blood flow and relieving that congestion in the lungs.
And of course, the specialized lower dose applications we discussed in the adverse profile section.
Cough suppression is a classic use, employing codeine or its derivatives to act on the medullary cough center. And, leveraging the very adverse effect we spent so much time on constipation, we use certain opioids to treat diarrhea.
And there are synthetic opioids formulated specifically for that, right? To minimize CNS penetration.
Absolutely. Loperamide and diphenoxylate are the key examples. They are synthetic opioids designed to have poor CNS penetration. They act almost exclusively on the enteric nervous system to maximize that constipating effect while minimizing the risks of respiratory depression or euphoria. They target the gut and only the gut.
This has been an absolutely extensive exploration of the pharmacology of pain. We started with the humble poppy and the prototype, morphine, and meticulously drilled into the complex and systemic effects from unavoidable chronic constipation to the life-threatening risk of respiratory depression.
We meticulously connected the dots, moving from the resinous material to the molecular keys, the mucapa, and the LOTA receptors. And we confirmed that every action of these drugs is a mimicry of the body's own sophisticated natural pain control system, operated by endorphins, enkephalins, and dynorphins.
The ultimate clinical takeaway for you, the learner, is clear. Opioids are indispensable tools for managing acute and chronic suffering, but their use requires a deep, nuanced understanding of receptor affinity. Whether a drug is a full agonist, a partial agonist, or an antagonist defines its entire clinical profile. And we must never forget those two actions that escape tolerance, meiosis and constipation. The balance between potent, necessary relief and the ever-present risks of dependence and respiratory failure is the critical challenge of modern medicine.
Indeed. and it forces us to constantly appreciate the ingenuity required in drug design. If we look back at the complex action opioids like buprenorphine, we see agents designed specifically to circumvent the risks. They provide profound pain relief by being a partial agonist at the high-risk mu receptor, thereby limiting the ceiling for euphoria and respiratory depression while also acting as an antagonist at the kappa receptor. This targeted design is the future.
Which raises an important final question for you to mull over. Since we know the dependence and the severe risk are linked so strongly to the full activation of the mu receptor, can future molecular engineering truly achieve the full necessary analgesic efficacy of morphine, the prototype, by using only selective agonism at the delta or kappa receptors, or through the combined action of partial agonists, thereby decoupling potent pain relief from the devastating dependence pathway? That remains the ultimate pharmacological and ethical frontier.